All right, well, it's probably time to get started. So I want to go ahead and kind of set the stage a little bit. One of the things that I loved during vision therapy, working in the clinic and everything, is Dr. Winters always set aside a certain part of the week, or at least once every week, where all the therapists would get together and we would have training. Either he would train us or he would bring somebody in that would train us, and then we would open it up, kind of open forum on some of our patients, and we would go through things. And those were always beneficial because it just seemed like we could learn from each other. We were just able to go through stuff. And that's kind of how I envision these series going, is just kind of bringing that back, that instead of being therapy clinic in Ontario, Canada, and Houston, and in Boston, and in Washington, let's just for a little bit, let's all gather into one room and let's just have a vision therapy discussion and learn together. Now, I do want to say that this therapy training that we're going to be doing is open to all vision therapists, all doctors that want to participate, or doctors that have certain staff members that they want to participate. But it is not intended for the general public, okay? So here's the disclaimer, everybody pay attention. All vision therapy should be done under the supervision of a licensed optometrist. So if for some reason that you're watching this, or in future if somebody sees a replay of this, if you're not a licensed optometrist or working under a licensed optometrist, I'm glad that you're learning about this, but please go to one that is qualified to be able to help you with this time. Now, these first few webinar sessions, they're going to be titled a Back to Basics series. I'm hoping by that it's not meaning that everything's going to be so basic that there's no value to it, it's not helpful, it's just so simple, but more that I want us to begin to lay the groundwork again of who we are, why we do what we do, what's the background of it, so that we really get an understanding so that we can go forward. So when we get into the deeper concepts, we have a foundation that we're building upon. And Dr. Winters, is that kind of what you're thinking?
Absolutely, yeah. No, I think that that's always important to lay the groundwork first before we can move into the deeper stuff.
So hopefully, can everybody see the slideshow underneath? Making sure that all our technology is working.
I don't see anyone saying no.
Okay, all right.
Can I just comment too?
Sure.
One of my favorite things about that training session that you were explaining about, that we had in our office, is just that back and forth, the questions that come back and forth. And so please, we really want this to be a place where that happens. So please feel free to put in comments and questions. That really makes this a lot more fun and interactive.
All right. So I guess we should start out to tell you who we are. It's easy to kind of just get into this and want to talk about the important things, but my name is James Smith. I'm a COVT. I'm also the trainer and for Emergent. I love therapy. It's one of my passions. And then this is my doctor, Dr. Winters. He's a fellow with the College of Visual Development. And it says guest speaker on there, but he owns the place. So this is his show too. So I just want all of us to be able to share things that we've learned. And if you're a new therapist, that you'll be able to put this into your toolbox and begin to use it. If you've been around for a while and you've been doing therapy a while, just to refresh your mind and to make it stronger so that when you pull it out to use it again, it's fresh. So a little bit of housekeeping. If you need immediate clarification, already I can tell that I'm talking fast, I'm getting excited, I'm looking forward to what we're going to talk about. There's a little hand emoji. You can sit there and wave it at us. If you have a question, there's one that looks like it's in motion, like it's really important. So if you have a question, you can also in the chat, if you'll type it question mark, put your question in it, and then end it with a question mark, kind of like the Spanish do. It'll help us a little bit to know that you have a question right away. So that being said, let's go ahead and begin. And I'm going to move something around here. So Dr. Winters.
Yes.
No doubt you've been asked over the years, what is vision therapy? Okay.
Yes, I have.
But before we get to that, I would like you to say, maybe could you share a little bit about what the history of vision therapy is and then where it all began?
Absolutely. So the really interesting thing about the history of vision therapy is that it actually began in ophthalmology, which is interesting given some of the scrutiny that we get from ophthalmology now. In fact, I was going back, and if you want to have a great history of vision therapy, the Applied Concepts in Vision Therapy by Len Press is a great place to go. There's a great history there. But there was a quote as I was just kind of refreshing as I was preparing for this question that I had forgotten about. This is written in 1904 at the turn of that century there. And this is an ophthalmologist, and he wrote, "The ocular muscles are not the reins to drive a horse or simply to move the eyeballs in, out, up, and down. But these beautiful anatomical structures of the eye are controlled and adjusted according to the laws of nature, and also controlled by the human being behind it all that must influence them in many ways." So I love that, because that's what happened, or where we got our start, is that ophthalmologists were doing surgery and finding that they were having varied responses, and realizing it's a lot more than just moving muscles around to be able to get the eye straight and working together. And so from there started to be some stereoscopic depth perception activities that would happen. But then about in the 20s is when optometry got involved, and we primarily got involved because of a man named A.M. Skeffington. And anyone that's been in optometry school, and I'm sure even a lot of the therapists know that name.
Right.
He's essentially the father of behavioral optometry. And so that's kind of where it evolved from there. I think A.M. Skeffington and then some of his colleagues really started to develop these concepts. And a lot of what we do today, you can still go back and see those roots right there. Those are the foundational knowledge still came from those great people that got our start back then.
Thank you. Now, I would like to hear kind of some of your heroes of vision therapy, and kind of what their philosophy was, and then how did that affect you in deciding in your career path?
Okay. So, boy, I've got a lot of heroes. You know, it's funny, when I was going to optometry school, I haven't always been just a VT guy. In fact, I remember someone coming up to me and saying, "Hey, what school are you going to?" I said, "Well, I'm going to go to Southern." And they said, "Well, why not in Pacific? Because we're from the Pacific Northwest." I said, "Well, they do a lot of that VT stuff, and I'm not sure I really want to do that." And so it was in my first year of optometry school that Dr. Carol Scott came and talked about the work that she was doing and the life-changing work that she was doing with kids. And that just intrigued me. So first of all, I have to give a big thanks to her, and just that drawing me into this part of our field. It has just been rewarding since then. But, you know, through school, we had Dr. Maples there. He's a big name in our field. And it's really funny because Dr. Maples, I remember in optometry school, you learn different things, but he had kids like rolling around on the ground. I was like, what is this guy doing? Right. And, one of the things that I struggled with in the beginning was, well, glaucoma treatment, you go to this medication and this medication and this medication, or, there's just kind of this typical, very detailed progression on typically how you treat a disease. In vision therapy, I was like, every vision therapy clinic I visit, it seems like they're doing things differently. It took me a little while to realize that the foundation was the same. It was just different activities to get to what we wanted them to do. From there, I took the SANET course, huge for me there. That SANET course really gave me the foundation where I felt comfortable starting my own vision therapy only clinic. There's a lot of other names that I would love to put out there, but we just don't have time. But yeah, is that kind of what you were hoping for?
Yeah, it is. And it's interesting because when I got hired, 3 days after my hire date, we actually went to a seminar by Dr. Maples. And of course, most of it was so far over my head because 3 days into it to be able to listen to all that and try to absorb it. but I'll always remember some of the highlights of it just seemed like he was doing magic with those wands, and that he was able to figure out so much just by simple little eye movements, or how the circles on a chalkboard would describe, all these different things. And one of the most powerful ones was just the visual memory. He used parquetry blocks and being able to close your eyes and be able to see those parquetry blocks in place. That kind of just opened up the world to me as far as what vision therapy is. And then as a therapist, of course, Linda Sannett is always going to be one of my heroes, just her compassion and passion for it, her insight, parquetry blocks, all these different things. So as therapists, what I'm wanting for you new therapists is to understand that there has been years and years of groundwork that has been laid. There are heroes that they've been in the trenches to say, hey, this is something that works. And we get to build on that. We get to take that step and then take it to the next level and really understand what we're doing. Now, Dr. Winters mentioned a little bit about behavioral or developmental. Maybe you could kind of differentiate that. What is the difference between an optometrist that is doing vision therapy versus just an optometrist, maybe what would better term, maybe common optometrist that you're just getting a pair of glasses?
Well, I think first it's important for all the therapists out there to know that every optometrist coming out of optometry school has had courses in vision therapy. So we've got this underlying knowledge. The problem is I've been there. I started my career as an optometrist at Costco. And at Costco, you've got 20 minutes with that patient, right? And I've got to check to get their prescription right. I got to check the health of the eyes. And, sometimes as optometrists, we don't look into some of these very important things as far as the function. Yeah, great, we got the right prescription. Yeah, their eyes are healthy, but how is that affecting their lives, right? And looking at, okay, these two eyes, they've got to work together. And if they're not working together, what kind of impact is that having on the person? So I think the differentiation is really, as developmental or behavioral optometrists, we're really looking at that person and how vision is impacting that person. I'm going to say right now, I hate the term behavioral optometry. Not because it's an incorrect term. It's an absolutely correct term. Vision is so powerful that we can affect the behavior of our patients. I just think it sounds funny to people. Like, wait, you behavioral optometry? What? Okay. So I typically prefer the term developmental optometrist or neurodevelopmental optometrist, but that's just my preference.
Excellent. So all that being said, what I would like to hear now is, how do you answer individuals? Because if we could see all your hands, every therapist that has ever been asked, what do you do? What is vision therapy? How do you answer that question?
I think we have some more slides here. You don't want people to think we're not going to get through our slides. We will. Absolutely. So what is vision therapy? Well, my quick and easy answer, let's go ahead and go to the next slide actually, and then we can come back to models of vision. But my little elevator pitch that I like to give people is, what do you do? Well, I do, vision therapy. What is vision therapy? Well, vision therapy is like physical therapy for the eyes, okay? And so we work with people to help them to, we work with people that have binocular dysfunction or difficulty using the two eyes together. And so what we can do is, with these activities, help people to align their eyes. We help people that have head trauma that's affected their vision. But where I spend most of my time is working with people that have what I call the silent vision problem. Okay, these are typically children. By looking at them, you'd never know that there was any problem.
Mm-hmm. Right. But
they're struggling with double vision, headaches, blurry vision, and you wouldn't know it, and they don't know to tell that to you. So that's kind of my elevator pitch, because it helps them to bring in. I'm hitting that we've got head trauma, and I think this is important because every vision therapist out there right now gets the question, what is vision therapy?
Right.
And you are some of the greatest advocates and the greatest ways that people out there are going to learn about vision therapy. And so if we can, basically I'm clicking through, okay, do they know someone that has strabismus? Do they know someone that has a TBI that's affecting their vision? And then, do they know a child that's struggling in school?
Right.
And I'm trying to get that so that if they do, that can be brought up and we can expound on it.
Well, I want to clarify one thing, because I've heard the term physical therapy for the eyes. But I remember when I tore my ACL playing basketball in college, that a lot of physical therapy was just re-strengthening the muscles. Is that what you're talking about, or is there something more?
Right, and we have to be careful with that. We're obviously not doing strength training, right? We're not doing, pencil push-ups just to get those eyes stronger, right? It's the coordination. And if you were to talk to a physical therapist, you'd find out that a lot of what they're trying to do is redevelop that appropriate coordination so the muscles are working together. But I say that just because it's easy. It's easy for people to identify with and understand. But absolutely, we're not doing strength training.
Sure. So just to cover that slide that we passed, one thing that Dr. Winter's been discussing was, the classical model. That's just making sure that, the function of the focus is on the 20/20 eyesight. And then that functional, everything in the normal ranges,
The reason I brought that up is I think you had asked, what's the difference between behavioral and a normal optometrist? And I think this is a great place to be, whereas there's just different models. Mm-hmm. Okay, we talked about me at Costco, okay, looking at the healthy eyes, making sure people have 20/20 vision. That's important. We need to know, can they get to 20/20? If you can't see 20/20 with a pair of glasses, then there's something else going on. We got to figure out what that is. So there's nothing wrong with that model,
right?
But let's take that a little further. Let's talk about the functional model, okay? Functional model is, okay, and this is a lot of what I learned in school, okay? Someone has convergence insufficiency. Well, let's do some activities to get them within a normal range. Mm-hmm. And if they get in the normal range, cool, we've done it. Well, that's good too. I mean, it's important to kind of know what is a normal range for people. But where behavioral or developmental optometry just kind of really takes it to the next level is it focuses on the individual.
Yeah.
And that's what I think, the people that are watching really need to focus on is it's so easy to get caught up in the numbers. Okay, we got to, whatever it is, number 20 on the vectogram today. Yes. But who cares if it doesn't translate into improving that patient? And some patients, a 20 is great, but some patients, if we can get them to a 4 or 5 mm-hmm. and we're accomplishing their goals, that's great too.
Right. And the effort, if they're getting to 20, but it's taken 100% effort to get there, then the system isn't calibrated correctly. So good answers. Now, Kathy Stearns also added that maybe occupational therapy for the eyes might be useful as well.
I like that.
Yeah, so that's a good way to put it. Okay. Now, here's my definition. And this is kind of what I've thought about through the years, is that vision therapy is that development of the brain through the visual system, and thereby allowing that brain to have more control and ease of the complex processes. This is both on a cognitive and a subcortical level. So I'm accessing
That's the one
the brain.
You tell people, right, whenever you're in the elevator with them?
No, usually in the grocery store.
Okay.
But the whole point is we're the brain is the key that controls everything, okay? And the visual system is one of the easiest ways to access that key. And so we create the environment, we help the patient to develop their own skills, and then that way they have a fully functional system. So that's kind of, as a therapist, what I want you to know is that you're not just some activity director, okay? You are literally on the cutting edge of science in developing brains for the future. Isn't that cool? All right, you can go and tell the next person you see at the grocery store that. So, all right. So that's kind of our background. So now let's kind of look at the last part of this session that we're going to be doing, hopefully here about 10, 15 more minutes. But identify your goals. If you're a therapist, you really have to identify what it is that you're wanting to do. So first of all, of course, a binocular system, okay? And in that, it's the all-encompassing. It is a visual system that is functioning on all cylinders and that is what it needs to be for that individual patient. But second is the remediation of symptoms. There's a reason those patients are coming to us. When they come to see Dr. Winters, whether it's a headache or blur or a strabismus or whatever it is, at the end of the game, we want to be able to look back and say why they came to us got better. That's just, if I went somewhere, that's what I would want.
They don't care if they have 20 arc stereo, right? They care about their symptoms, what they came in for.
Okay. And then lastly is maybe even something that they don't realize can even happen, but better life enjoyment and better experience. Okay. I don't know how many people that have come, maybe even just for strabismus. I remember one lady specifically who broke down crying because she spent 20 minutes just looking at the lace of her baby girl's dress, because she had never seen depth, she had never seen contour. And so just that better life enjoyment of being able to appreciate beauty is something that we have the ability to help them and to give. So what I'd like to do is we're just going to break this down into the main areas of vision therapy, okay? So again, very basic, but we're going to talk about ocular motor, okay? So oculo, the eye, motor movement. And so everything begins with, we have two cameras and they've got to get from one place to another place, and they have to be able to stabilize on whatever it is that we're fixating upon. So we'll be talking about ocular motor. Accommodation. Once the camera gets to where is supposed to be, it's got to make that image clear. So being able to understand what is accommodation, how do we make things clear? And then binocularity, that's both of those cameras, both eyes working together, not only on the x-axis and the y-axis, but also on that z-axis, being able to converge and diverge. And then the last one that kind of brings into what we do is visual processing. The first three, they are getting the camera to the place where it can absorb the information. The last one is what the brain does with that information. And so making sure that there's a clear communication path between the visual system and the cognitive system. So Dr. Winters, let's just kind of go through the ocular motor. So monocular, one at a time, biocular, two eyes, but not with fusional ability, binocular. Is this a linear approach, or how would you say this is structured?
Totally depends on the patient. We hate those answers, right? But it really does. Generally speaking, I think we try to follow, you want to get each eye individually to where they're functioning well before you go start trying to put the two together. But that can be different. I mean, we have strabismus patients that come in that we're wanting to work on gross fusion that very first day. Right. Get some red green glasses on a white board and just trying to get that peripheral binocularity. So it really does depend on the person.
And so that's how we have to begin to think about it, is these are all ways to break it down, but it depends on the goal that you're trying to do. So you're establishing the goal. So yeah, there's times that I may use an occluder. Now we use a translucent occluder. I hardly ever, in fact, I don't remember the last time I've ever used an opaque or black patch type thing. But helping them to know how to fire and how to move that eye, and then how to move the opposite, and then how to move them together. So these are just different ways that you would break it down monocularly. Sometimes if I'm going to be doing a monocular activity and there's a patch, I'll still look at that eye that's behind the patch, okay? Because even though I have a patch out here, the brain still knows it has an eye. And so sometimes when you're moving that wolf wand, you'll look to see where they connect, and where even behind the patch, that one is trying to work in coordination with that other one. And that can help you to begin to get that pairing. But then binocular is to get those two eyes, but they have fusional ability. So let's break down these ocular motors. So the first one is fixation. That's just pretty much what you're looking at. And so one of the things I'm very careful of is not to confuse terms, okay? How many of you people have said, hey, focus over here, or focus on this, or focus on that? I only use the term focus for accommodation, okay? Focus is to bring something into focus or to bring it into clarity, okay? If I'm talking about fixation, I want to use words like, would you look at, or touch, or localize, or see, or fixate upon. I don't confuse those two terms, because this is the foundation. Everything else, if you can't, how many of us have had that little child that we say, hey, look at me, and they're like looking all over the place, and you're like, hey, look at me, and they're like, I am, and they're not, okay? If they can't fixate, if they can't hold stable fixation, then there's no way that we can move on to some of these other activities. All right. Saccades. What is your definition of saccades?
Eye jumps. I mean, simple, would be, but basically that you're taking your fixation and then moving that fixation to another point very quickly.
Okay. And I don't remember who I heard this from, but it was very early. I think it may be even when I was studying for COVT. But it was two fixations separated by a ballistic eye movement. And I always thought that was pretty neat. You have two stable fixations separated by a ballistic eye movement. And then pursuits, it's pretty easy. You're just pursuing, you're just following that through space. So this is keeping a single fixation followed through an area of space.
So one question I'd put out there to everybody is, which of those do we use most? Fixation, saccades, or pursuits? Which is the majority of our day filled with? And believe it or not, it's saccades. We hardly ever do a pursuit. Pursuit, like in sports, maybe, right? Mm-hmm. But generally speaking, even when we walk into a room, we're making a lot of different saccades to take in that information. We can't typically see it all. So our brain is really good at just piecing together these ballistic eye movements, these different fixations that are happening. And so that's important for you to know that that's a really key one that they need to be able to get good, accurate saccades.
And if you really think about it, as we learn, a lot of learning is through reading. And so those are little tiny saccades. And so being able to know where your eye is and where it's going and be able to make that in a smooth jump is very important.
You had on there, I know some personalities like everything that's on the slides to be discussed. So,
okay, go ahead.
Just the central and peripheral magnocellular parvocellular.
Yes, I'm glad he caught me on that, because this is the glue that holds it all together. All right, so the magnocellular, those of you that I've ever been able to talk to or we've ever done training together, it's very important, because that periphery is the where, okay? And we have to identify where something is in space in relation to ourselves, and that will help us to triangulate, to find fixation and to pursue and to do all these different things. But that glue, that that periphery also helps us to get with our stereopsis. It helps us to hold everything together and then direct us towards that central or the parvo. In the parvo, it's going to be detail-oriented, is where we identify what things are. It has to deal with accommodation. So being able to know what those do and the pathways that they follow is very important. And as you begin to guide your therapy, you're going to guide it from that magno-peripheral area and then bring it in closer and closer to that central area until they have control of both areas.
I mean, how many times have you heard, focus on the ball, right? Focus on the ball. That's not what we should be saying when people are trying to hit that ball, right? We should be saying, put that ball in context with everything else, because they need to know the where. If we focus on the what, and what are we focused on whenever we're reading? What, we lose track of the where. So if you're going to improve fixation, focus less on, hey, how come you're not looking right here? But taking in all of that peripheral vision with it will help them to get better fixation.
Okay, accommodation. Once we're looking at something, how do we make it clear? Okay, so this is the process which the eye changes the optical power to maintain a clear image. All right. Now, Dr. Winters has already told me, I'm not sure if this is a scientific word or not. Okay, so we're talking about flexation, the act of flexing, or true accommodation, accommodating the system in order to clear that objects are close. So that lens that is in, if we want to see something close, we have to flex and we have to make that lens come down, and it reorientates the light and helps us to view things that are close to us in clarity, okay? If something's farther away, then we have to relax the system and flatten it out, and it allows us to be able to see light. Now, I have to say that seems counterintuitive. It's because how many of you have said, hey, look at that way over there, and people are like straining to see how, something that's way in the distance, because we a lot of times think the farther away something is, well, that means I'm having to work harder to see it, when the opposite is true in accommodation. So one of the greatest things that you can ever teach your patients is the ability to know that sometimes less is more. Less straining and trying is going to open their periphery. Less, accommodation and tightening of the muscles is going to open it up and allow them to see farther. And then knowing that flex and relax.
Yeah, I think it would be, hopefully everyone's done this, right? But to cover up an eye, to look at your finger and notice that everything in the back is blurry. And then focus on that in the distance and see that up close finger is blurry. And you can actually watch that lens, because that's the only thing that's changing, right? Maybe your fixation is changing slightly, but the big thing that's changing is that lens inside the eye is changing. Flexation, I like that. That's exactly what's happening.
So one of the things that I have found, and this is maybe just a little clinical pearl, is we're doing a lot with children that have very low muscle tone, okay? They really don't know the feeling of flex and the feeling of relax. So if you're doing the bullseye activity, or you're doing a near-far heart chart, and you're asking them, okay, you're seeing the far chart and it's clear, you're seeing the close chart, it's now you've made it clear. How did you do that? And if they don't know, and they think that looking far is flexing and looking close, sometimes I'll just have them make a fist. And I'll have them make a fist, and then I'll have them tighten that fist, and I'll say, now, do you feel what that feels like? Yes. Okay. Now relax it. Do you feel the difference of that? Yes. Then I'll go back and I'll have them look at the close one, tight on that bullseye, and then relax and look far and look through it. And then I'll ask them, which one felt more like when your fist was tight? Which one felt more like when your hand was relaxed? And trying to help them to understand what that feeling is, because it is key that they learn the feeling of flex and relax of their accommodation skills before you ever begin to work on convergence and divergence, okay? Because if you're not careful, you'll create a mismatch in their brain, and they'll correlate the flex of accommodation and the flex of convergence as the same thing, and that you don't want to do.
Absolutely.
All right, binocularity. How many of you would like patient number 1 at the top? That would be fun to work with, all right? But binocular vision is just amazing what the human visual system is able to accomplish, okay? And so it's the type of vision. We're made to have 2 eyes. We're facing the same direction, but at a slightly different angle. So therefore we can have 3D. For people that have never seen 3D and finally they see stereopsis, it is such a rewarding, awakening time, okay? And so full visual experience, they have depth of field, stereopsis, have clarity, full function, okay? So you want to be able to, that they can diverge and converge, but maintain clarity on all those points of that z-axis. That is the goal of binocularity. Also termed eye teaming, getting both eyes to work together. And so this is the goal. So Dr. Winters, will you kind of explain a little bit about what the need is? What do we have to accomplish for them to have binocularity?
Well, hopefully everybody that's watching knows that binocularity is when we're using the 2 eyes together. But my next question will be, if the eyes are not focused exactly on that same point, okay? They're not both pointed, make sure it's in the camera, like on my finger here. Can they have binocularity or not?
I'll give you a chance to answer. So are you talking about aphoria, or are you talking about?
I'm just saying, can you be binocular if your eyes aren't perfectly aligned?
Yes.
Yes, okay, and that's important because that is a tool that we use often, particularly with people with strabismus, that, hey, we're trying to get some gross peripheral stereo, maybe that central area of alignment, okay, where we get like the double vision. is being suppressed, okay? But they have that peripheral vision that is being fused together. So yes, that first bullet point, motor alignment, both eyes are aligned on the X, Y, and Z axes. Yes, but if they're not perfect, doesn't mean that there's not binocularity going on. We want sensory fusion, both eyes on at the same time, working together to form a single precept, I like that. So single perception in the brain. Stereopsis then takes that and then turns that into a depth perception, right?
Yeah. So if you kind of think about it, the cameras take in the light, the brain moves the image into a single thing. So part of it is done within the eyes, but the main part of sight is done within the brain. So they have to all work in tandem. And so Dr. Winters is absolutely right. There's many times that we'll use peripheral fusion to help guide motor alignment and help bring it in closer and closer until they can get that full sensory fusion in both their periphery and their central.
Stereopsis, just real quick. You ever gone to a 3D movie and close your eye? You'll see that goes away. So how does that work? Well, there's a little bit, this eye sees something a little bit different than this one, and that brain interprets that little bit of what we call disparity into depth.
Okay. All right. Okay. And now last is basically visual processing. Now, visual processing is a huge list of different things. You have discrimination, you have figure ground, you have closure. There's lots of different things that are going into that can be broken down into what we call visual processing. But what I want to talk about for this basic part is visual processing is just the brain's ability to use and interpret the visual information from the world around us. So, if you're getting bad input, okay, if your eyes aren't giving you the right information, you're not going to be able to have good visual processing. If you have conflicting, okay, so strabismus, one eye is off and one eye is straight, it's conflicting. The brain has to say which one is real, okay, which one is telling me more of the truth. If you have amblyopia, one's clear and one's blurry, the brain has to decide. And so that's why suppression comes in, or all these different things. But even once you get them to where they're getting good information, now we have to see, is the brain doing something with it, and is it creating, okay? So input is what we receive through our senses. And you have to remember that vision trumps all other senses. Great book, John Medina, Brain Rules, okay? A great book, talks about how vision trumps. And all of us have had different times where if you touched something and it felt hot and you looked over and it was an ice cube, well, your finger felt one thing, but once you saw it, then you recognize, oh, that was actually cold. So being able to understand that vision is a powerful tool to access this information processing system, okay? So input is what we receive through. Now the next one, put. I think this may be another one of my technical terms that came from Greek somewhere, but I actually heard this and I loved it. And I put the choo-choo train because when I was thinking this, all I could think of is the little train that could, I think I can. Okay. So the input comes in through the visual system, then the brain begins to process the information. And then the throughput is the outward process determined. Okay. So when you're doing your activities, make sure that you kind of think about, what is it that I'm wanting them to do? If you're just doing the heart chart, okay, it has visual processing involved in it. They're having to look, they're having to discriminate, they're having to recognize, and then they're having to think. That put is going on within their mind, and then you have a throughput that you're asking them. You're asking them to say the letters O, F, N, P, V, D. You're asking them to do it at a certain time, certain beats of a metronome. You're asking them to add, whether it's standing and walking, all the different things that we're loading is things that will complicate this visual processing. So ocular motor, we've got to help them to get their eyes to the right place at the right time, okay? Accommodation. We've got to help them to understand what they need to do to make things clear. It's not just, oh, it just happens. Okay. It's just there. And then binocularity, giving them the opportunity to have the best binocular experience that they can. Why all that? So that we can get to this place, that they can have a visual processing system that is firing on all systems. That's what's going to help them to become successful wherever they are in their stage of life. If they're children, we're giving them a great way to start out, okay? If they're in their middle ages, then it's giving them a solid foundation for college and for jobs and everything else. And if they're older when they're coming to us, we're giving them a better quality of life. And let's face it, being able to have better cognition in our latter years is very important nowadays. And so hopefully we're about out of time today, but hopefully this gives you kind of some of the building blocks that we're going to be dealing with. And then next month and the months after, we'll begin to break these down and take them to another level.
Let's talk a little bit about maybe some of the things that are going to be coming down the road. And a lot of this we want to come from you too. Let us know if there's a certain topic that you want us to address. But I envision us not only going through kind of theoretical things, but actually doing activities and talking about different ways that we would come to an activity. We've got lots of ideas, but yeah, we want to hear from you as to what types of things you'd like us to discuss.
Yes, so you can always email us. Our email information is out there, or you can always go to our website, emergentvt.com. And yeah, we would love to know what you would like us to talk about. I would like to go over the polls. So 4 people answered the first poll, which was 44% of the audience. So maybe if some of you still want to answer, you can. But all 4 answers were the 6 through 12-year-olds. So that's pretty much telling our wheelhouse, who we like to work with, those early school years of children, okay? And then the type of patient diagnosis that scares you the most, it's split 50-50. Here we go, exotropia and esotropia. So that will be a great class when we get to those 2. So always remember both of them, peripheral, gross peripheral, fusion to central, okay? And work from there until we can break it down a little bit more. But we thank each and every one of you, and please email us, let us know how we did today. If you have any comments of things that we can do different, we'd love to hear it. All right. Thank you very much for joining us. Bye.